question.
Okay.
Right. So considering this critical care scenario, if you have read and understood, kindly tell me how would you manage this patient now?
Okay. So as this patient is having a suspected peptic ulcer disease,
Yes.
perforation, so
Yes.
is a critical patient. We have to manage the patient according to the CCR-ISP protocol.
Very
So I
good.
will check the airway, breathing, circulation,
Yes.
disability, and exposure. So I will
Yes.
talk to the patient if he is able to talk or not.
Yes.
If he is able to talk, that means airway is patent. Then we have to look for breathing. If he's breathing
Yes.
well, we can check the monitor for saturation. If he's breathing well, then I go for circulation. So we have
Yes.
to open 2 wide-bore cannula and start IV fluid, preferably crystalloid. We have to check for blood pressure, capillary refill, and we have to talk to the patient. We have to check the altered mentation as well. And then we'll go for disability and exposure of the patient.
All right. Considering that patient has atrial fibrillation and patient is already taking warfarin, what measures would you take into consideration?
Okay, so if the patient is already on warfarin,
Yes.
but as is a emergency condition, so we have to take the patient to theater.
Yes.
By this time, we can send for some blood test. We can do full blood count, urea electrolytes, ABG, and INR as well.
Yes.
And from there, we can already start injection vitamin K. We can give, we can ask lab to prepare fresh frozen plasma cryoprecipitate.
Yes.
And then we have to take the patient to theater upon discussing with the relative and the surgical consultant and the anesthesia and theater team.
Considering that it's a critical care scenario, how would you take care of the fluid requirement of this particular patient?
Okay, so for this patient, as is already on warfarin, so having some problem in the cardiovascular system, so we'll go for 250 ml or 500 ml crystalloid fluid over 15 hours, and then we'll if the response is not good, we can repeat up to 4 times.
Okay, just suppose it's gone under compression. 5 post-op day this is, right? And
Okay.
yeah, sorry, I should have corrected that before. Right, if you just considering the scenario right now, if you'll do the ABGs of the patient, what do you expect to see?
So maybe the patient might have metabolic acidosis.
Not maybe, confirm you're telling. Okay, then
Yeah.
what else?
Then
Yes,
we have to look for lactate level. Is there
yes,
any lactate
yes,
might be high, and
yes,
then we have to look for electrolyte as well.
yes,
We have to check, and we have to check the hemoglobin as well. How is the
yes.
hemoglobin? Is it
Con
dropping or not?
yes, considering there is hyperkalemia, what would you do? How would you manage that?
So we have to start with 10 millimole of calcium gluconate over 10
Okay,
minutes.
yes,
And then we can go for 50% dextrose with 10 unit of extra with, I mean, insulin on the drip. then we can run that one over 30 minutes. Then if it is still not improving, we might go for salbutamol nebulization, and then
Yes.
we can think about sodium bicarbonate.
Yes. Or even you can give insulin with 5% dextrose.
Yes.
Ion exchange resin therapy, and if nothing improves, then the last resort, hemodialysis. Right.
Yes, ma'am. Yes.
Right. Okay. In this condition, there's in this scenario, there's a condition called SIDS, which is most commonly seen. Which of the
Yes.
SIDS factors are positive in this particular patient?
Okay, so SIRS is a systemic inflammatory response syndrome.
Yes.
So we have to look for, okay, here there's nothing mentioned about the vitals.
No.
So we have to look for blood pressure, we have to look for
So,
respiratory rate, we have to look for pulse, and
yes,
we have
a
to see,
certain criteria which is mentioned that it's elderly patient and post-op.
yes,
So considering
okay.
or keeping this in your mind, how would you
Mm.
manage the patient? Like what
Okay,
would be
ma'am.
the,
So we have to look for those vitals, blood
yes,
pressure, and then pulse,
yes,
and the respiratory rate, and then we have to look for white cell count,
yes,
and then temperature, and we have to look for
and
urine output as well.
very good.
Mm.
How much
And
should be
then
the
we can,
normal urine output, which should not be,
it should be 0.5 ml to 1 ml per kg body weight per hour.
yes. Okay, if patient happens to present with null output, what would you interfere from that, or how would you confirm it?
Okay, so we have to make sure the catheter, is it blocked or is it patent?
Yes,
If
yes,
it's patent, then we have to send some blood, renal function test, urea creatinine, and electrolytes.
yes,
Then we have to measure the urine hourly.
yes,
If is less than 0.5 ml per kg per body weight per hour, then we have to look for blood, fluid, how much fluid he received post-operatively, is it adequate or not? We have to start fluid challenge. So
yes,
after giving fluid challenge, if still there is no urine output, then we have to consult with the ITU specialist and maybe the renal team.
right. Okay, since the patient is taking warfarin, how do you monitor or how would you confirm or rule out patient is not suffering from warfarin overdose?
Okay, so we have to send INR blood
Yes.
test. So if it's like in normal range, we can rule out is the patient is not on
What do you
warfarin, and then we
consider
have,
normal range, please?
so is
Specify
2 to 3.
between 2 to 3. Okay, 2.5,
Yeah.
right? Yes.
Yeah, and we
Then,
have to look for, is there any bleeding from any side, like any orifice, mouth, then urinary catheter, or from the wound. If there is
yes,
no bleeding, then also we can think that is not warfarin toxicity.
right. Okay. How would you consider managing atrial fibrillation?
Okay, so we have to look for the cause. So in that case, as the patient is post-op elderly patient, patient is having electrolyte imbalance, as you said, is hyperkalemia and maybe sepsis. So we have to treat that one. And then
Yes,
after that, we can control rate, we can control rhythm, and we can we can give anticoagulant. So for rate control, we can give beta blocker. For rhythm control, we can give amiodarone,
yes,
and then amiodarone for 300 milligram over
yes.
30 minutes, and
Okay,
then 900 milligram over 24 hours. And if it's still not controlling, then we can give for DC cardioversion shock.
yes.
And for
Can you
anticoagulant, we
please,
can give,
yes. Can you
yes,
please
we can
mention
give,
the few causes or mention few causes of atrial causes of atrial fibrillation in a surgical
okay.
population patient?
Okay, so it might be electrolyte imbalance like hyperkalemia. It may be for hypothyroidism. Hypothyroidism is for sepsis, infection. and then maybe a postoperative patient.
How would you confirm that it's atrial fibrillation on ECG?
Okay, so we have to look for an ECG. We have to check maybe the P wave absent, sawtooth appearance, and then maybe arrhythmia.
Just absent P wave.
Yeah, absent P wave, yes.
In ECG, nothing else. Okay, good. Thank you.